And now we are live on YouTube. And you can start. So, hello everybody. My name is Yahya Ithawi. I'm a consultant physician fellowship program. And today I'm delighted to present my senior, my friend, my colleague, Dr. Yasser, well-known speaker, and he will enrich us today about hemodynamics.
Okay. Yeah, thank you very much. Yeah, thank you very much, Dr. Yahya. It's my honor and pleasure to join your group and to present the basics of hemodynamics as like requested. Dr. Yahya Ithawi, we know each other for 10 years, and like I'm not his senior, we are colleagues for a long time. We continue to collaborate actually after he started his career in Dubai and Asharga, and like he's doing amazing activities, and I'm really impressed about his program. So it is my honor today to be part of his amazing group and present one of the important topics on hemodynamics. So today we have two parts. The presentation is two parts. The first part I will be talking about basics of hemodynamics physiology. And please keep your question until the end of the presentation. We have about 10 minutes.
Sorry, yeah. You can text me the questions and I can present the question at the end. But if you want to speak the question, it will be at the end. But during the speak, if there is a questions, you can chat with me, send it to me, and I will present it at the end. Sorry, go ahead.
Sure, yeah. Feel free to send the question, text the question at any time, but the discussion of the question will be at the end. Okay. And the second part will be about case scenarios. We have two interesting case scenarios, and I will be using a new clinical decision software or a system which can support your decision and making calculations, which is really interesting. And we have been working to develop the software for a long time with some collaborators. So it is my pleasure today to present the software with you, and we'll discuss two case scenarios through the software. Okay, so let us start. And when we talk about physiology-oriented practice, it is kind of practice that based on understanding of physiology and moving away from empiric therapy and the controversy of evidence if you don't have a good evidence to support our practice. And we'll focus on cardiovascular and hemodynamics because physiology-oriented practice can be also can be focused on respiratory-related issues, can be related to neurological issues. But today we'll just focus on cardiovascular issues and hemodynamics. I have four main objectives in this presentation. And number 4 is the magic number in this presentation. So the first objective, I will discuss the basic physiology of hemodynamics. So how the systolic, diastolic, and mean blood pressure created by the hemodynamics system or cardiovascular system. And I will discuss also the 4 basic mechanisms of compensation when there is any compromise of cardiovascular system, how the body compensates for that. The second objective, I will discuss the 4 different categories of hemodynamic instability. Number 3, for each category, I will discuss how to assess the hemodynamic instability and by relying on clinical presentation, echocardiography, oxygen indices, including the utility of near-field spectroscopy, and how to understand, integrate everything all together to understand the physiology. And after that, how to formulate a physiologic-based medical recommendation based on integrating everything. So number 4 is the magic number, as you can see here. So we have 4 main mechanisms of compensation. We have 4 different categories of hemodynamic instability. And we have 4 steps of assessment: clinical presentation, which is the most important, but when we discuss the hemodynamics, you will realize eventually that the clinical presentation is very limited, and we have to add more tools, including echo, oxygen indices, and integrating everything all together. And then how to formulate a physiologic-based medical recommendation at the end. So models of practice, we are talking now about a physiologic-oriented practice, but what are the models of practice? One of them is empirical management. Empirical means that you're assuming that everyone is the same and just consider one way of assessment and consider management based on that. And I will give you an example. The other example is evidence-based practice. And the third model is physiologic-oriented practice. And there is limitation for each one of them. The first one is very limited, and I advocate to avoid doing that if possible. So empirical management means that you have just one way of assessment. For example, if you are trying to manage hypotension in term or preterm infant, assuming that the blood pressure just equal to his gestational age, and that's the same for everyone, and using the same way of management. Start with dopamine, and then until you reach a maximum dose, which could be 20 or 30 mics per kg per minute, and then using a second agent, which is fixed for everyone, like dobutamine, and then adding epinephrine and so on. So keep adding medication empiric without understanding what is the underlying physiology. And then the second model is evidence-based practice, when there is a clear answer from evidence, which unfortunately it is not the case in hemodynamics. Evidence-based practice is very helpful if you have very clear answer with very high quality from the evidence. For example, if you are treating RDS with the surfactant, we know that RDS is just one disease of surfactant deficiency in preterm infants, might happen in term. So you are treating that with the surfactant. So if you randomize 2 arms, either to give surfactant or give placebo, the answer will be clear at the end. If you are using nitric oxide to treat pulmonary vasoconstriction, then you have 2 arms, either to treat with nitric oxide or to treat without nitric oxide. So the answer will be clear at the end. But if we manage a heterogeneous condition like cardiovascular instability, like shock, with reduced blood flow, it can be due to very like various conditions, and we should not treat all of them as the same way. So evidence cannot support us to treat such heterogeneous conditions. And one of them is the hemodynamic instability or cardiovascular compromise. In this presentation, I will be focusing mainly on hemodynamic instability for infant with assumed normal heart anatomy. So we're excluding congenital heart because that's different approach, either obstructive physiology or any kind of single ventricle physiology. The hemodynamics is more complex and different. So now I'm focusing on hemodynamics with assumed normal anatomy of the heart. So let us move on. So we need to understand how the body compensates for cardiovascular instability. And the body compensates for that by different mechanisms, and the steps of compensation, as I mentioned before, 4. Remember the number 4 as a magic number in this presentation. And before we discuss the 4 main mechanisms of compensation, remember that we have in our body 3 systems responsible to maintain the oxygen delivery, which is the main goal of maintaining cardiovascular stability, to maintain normal oxygen delivery, and to maintain aerobic metabolism at the cellular level. So we have 3 systems: respiratory system, cardiovascular system, and the blood, which carried by the cardiovascular system to carry oxygen to the tissues. And the 3 systems should be working all together. Today, we will focus mainly on the cardiovascular system, which with the unstable or insufficient blood flow, which is the ultimate goal of cardiovascular system, then the result will be ischemic hypoxia. So if you are talking about this list, to deal with the hemodynamic instability, you need to know the physiology of cardiovascular instability, including everything in this list, including low systemic vascular resistance, which is, I consider that as the first in the list because of the most common cause of cardiovascular instability, vasodilator shock or vasodilator physiology. When you have some infant with septic shock, for example, and it is not a cardiac issue, it is vascular issue. So you have low vascular resistance and vasodilator shock. In this condition, it should be treated by vasopressor and should be dealt with approach which is consistent with the physiology, and we'll discuss that later in more details. The second one is hypovolemia, when you have low volume, and the low volume can be intravascular, loss of volume, like decreased volume from intravascular compartment to extravascular compartment, or can be a loss of volume outside the body, like hemorrhage. Poor myocardial performance or cardiogenic shock, and can be a high afterload, which means that you have vasoconstriction or increased resistance and the heart cannot contract against that high resistance. You may have left-right shunt, which is distributive hypovolemia. So the blood volume all over the body is normal as a volume, but the distribution is abnormal. For example, left-right PDA or AV malformation. You may have anemia, you may have hypocarbia, which is contributing significantly to decrease the blood flow. Low CO2 means significant cerebral vasoconstriction. Or compromised autoregulation or low oxygen delivery. And at the end, when you have low oxygen delivery, insufficient to maintain normal aerobic metabolism, you will have the end result as anaerobic metabolism. And then after anaerobic metabolism, you will have end organ dysfunction, including kidney, suprarenal, brain, liver, and gut. So let us discuss that in more details. So oxygen delivery, as you know, it is product of three things. And you can calculate that at the bedside. If you know the blood flow, and we are using the cardiac output as a marker for that, and you know the hemoglobin, you know the oxygen saturation, you can calculate the oxygen delivery. And oxygen delivery is a normal value between 20 to 40 ml of oxygen. And with any condition affecting either the blood flow or hemoglobin or saturation, the oxygen delivery will decrease. And the body can maintain the stable state of oxygen delivery all over the hour, from second to second, through the nervous system, by the autonomic nervous system, basically maintaining normal heart rate, maintaining also the humoral factors, maintaining the vascular stability and vascular tone. And if you look at the monitor, if you have a kind of advanced monitor, can give you the histograms. The histograms for all of the vital signs will be like normal distribution curve, as you can see here in this graph. The heart rate is maintained as normal distribution curve, the respiratory rate, the oxygen saturation, and the blood pressure. But once you lost the stability or stable state, then that's the first degree of decompensation. You will lose the distribution curve. And then one or more of the vital signs will be shifted either to the left or to the right. So you'll have more tachycardia or bradycardia, you have tachypnea, or you have perfusion in the index skewed to the left or the right, and the blood pressure will be abnormal. And if the decreased vital signs or unstable state is beyond these factors, then the next step will appear, which the body will try to maintain oxygen delivery through the autoregulation. And the autoregulation means local release of nitric oxide by tissues to maintain normal blood flow, because the nitric oxide is vasodilator, and the vasodilator means normal blood flow. And we have in our unit the combination or the integration between the pulse oximetry for the saturation, because you have only, if you have pulse oximetry, you have only half of the picture, you have only the arterial saturation. But if you know also the venous saturation or the tissue side, you can understand how much oxygen consumed by the tissues, and you can know the level of compensation. If you have the saturation decreased or the blood flow decreased, but the tissue level of oxygen is still maintained, it means that the autoregulation is still intact. So the tissue is still releasing nitric oxide, and there is no change in the tissue oxygen. But once you have this number, which can appear on the near-field spectroscope, if you have it, you will have the next level of compensation, which is the tissue will try to extract more oxygen, and you will have the number on NIRS now decreased. So here in this graph, you have the y-axis representing the tissue oxygen, and you have now the numbers really low. It should be between 60 and 80 roughly. And then you have it 45. Why? Because the blood pressure in the above curve here decreased. So you have the blood pressure, you have the three lines representing the lower one, the bottom one is a diastolic, mean, and systolic. And all of them actually dropped. You have collapse of blood pressure, collapse of circulation, and very narrow pulse pressure here. A pulse pressure, as you can see, are only 7 millimeter mercury. And then after the start of medication, everything normalized, the blood pressure normalized, and the tissue oxygen increased. So in this situation here, it is a third mechanism of compensation, which the tissue try to compensate by extract more oxygen from the reserve at the venous level. Assuming that the oxygen delivery is decreasing more beyond this level of compensation, then the next level or the next compensatory mechanism, which is anaerobic metabolism. There is not enough oxygen now, and the oxygen delivery is very low. Very low means that you have less than 10 ml of oxygen per kg per minute delivery. Then the tissue will start to rely on a different mechanism, which is anaerobic metabolism. In this stage, you have now the oxygen delivery in this graph decreased below the 10 milliliter of oxygen per kg per minute, and oxygen extraction reached the maximum. The tissue cannot extract beyond 60%. At this level, you have lactic acidosis. So once you see the lactic acid high in the blood gases, means that you are too late. It is too late at this stage, and the body already passed through all of the compensatory mechanisms, and you are just one step before end organ dysfunction and tissue damage, and eventually death.
بتقول ايه؟ قول لي بس.
Dr. Yahya, if you can just mute everyone. Please mute your microphone to avoid the background noises. Thank you. So in this graph here, we have a design of NICU, a design of infants with significant compromised oxygen delivery. And oxygen delivery can be due to decrease the blood flow anemia, or can be due to oxygen saturation. So we have two categories here. So if you move between beds in NICU or even pediatric intensive care or adult intensive care, you have two main categories. You have category of patient with decreased oxygen saturation and normal blood flow and normal hemoglobin. So the main issues are related to respiratory system. Or you may have the issue related to the blood flow, which could be the focus on this presentation, low preload, could be low systemic vascular resistance, or could be high afterload, or poor myocardial performance, or left-right shunt, as we'll describe in more details. And we categorized all of these mechanisms in four main categories. And again, just to summarize how the blood pressure created, and the blood pressure, I mean not the mean blood pressure, I mean the diastolic and the systolic blood pressure. So the heart as a pump will create a pressure above the baseline pressure of the body, which is the diastolic pressure. So the heart will contract to create enough pressure, and this pressure should be enough to eject the stroke volume outside the heart. And this pressure should be just above the diastolic pressure by certain degree, enough to eject the stroke volume. And stroke volume, roughly, it is 1 to 2 ml per kg per heartbeat. And this pulse pressure, it is variable according to gestational age and according to the age postnatally. So during postnatal transition, it is between 10 to 15 millimeter mercury. Beyond the neonatal transition, beyond the first day of life, you should have pulse pressure close to 20 millimeter mercury. Enough, and this pressure is enough to create a stroke volume. And then once the heart ejects the blood, the aorta, which is rich in elastic fibers, there is no any muscular fibers in aorta, and the great arteries, the aorta will enlarge and will expand to absorb some of the pressure created by the heart. And this pressure will be absorbed and will, when the aorta and large arteries recoil, this pressure which with the created with the recoil will create the diastolic pressure. So the origin of the diastolic pressure is originated from the heart. When the heart pump, the elastic fibers of the aorta will enlarge to absorb some of the pressure, and this pressure will be with the recoil created to maintain the diastolic pressure. And this diastolic pressure will be propagated to arterioles. And then arterioles, there is no elastic fibers. We have only muscular media, and with this muscular media, the tone is controlled by autonomic nervous system to maintain the diastolic blood pressure normal. So now we'll understand that diastolic blood pressure is reflecting two things. The first thing, which is the vascular resistance. So the resistance is maintained by the muscular media of the arterioles. The second thing controlling the diastolic blood pressure is the volume of the blood. So if you have decrease in the blood volume, then you have drop of the diastolic blood pressure. If you have decrease in resistance, you have the drop in the diastolic blood pressure. Systolic blood pressure is reflecting the pump action of the heart. So the systolic blood pressure as a number is reflecting how the heart is powerful enough to create a pulse pressure, and also is reflecting how much blood in the heart, which is a stroke volume. So the systolic blood pressure is reflecting stroke volume. You have low stroke volume, or you have low venous return, because the stroke volume should be equal venous return, or weak heart, then you have low systolic blood pressure. If you have low vascular resistance or low overall volume of the body, like dehydration, then you have the low diastolic blood pressure. And then we have the capillaries, which is, there is no elastic fibers, there is no muscular media, but they are very thin and fenestrated and responsible for exchange of gases and nutrition. At the end, you have the venous tree, which is the capacitance part of the circulatory system, and reservoir to adapt for extra volume of blood. If you infuse, if you give extra fluid, will be compensated and adapted by the vascular, the venous tree. Or if you have dehydration, the venous compartment will collapse or will contract to support the body with extra blood. Now we'll move to the actual clinical, try to apply our understanding of physiology on the clinical practice. In our clinical practice, we have three main markers in daily that we consider in daily basis to understand or to know if the infant is decompensated or not. Either low blood pressure or lactic acid, and as I described before, lactic acidosis means that you are too late, or decreased urine output, because of the kidney is very sensitive to decreased blood pressure. So the first organ like to be affected by decreased blood flow is the kidney. So we are considering decreased urine output is very helpful marker to understand that the body cardiovascular system is decompensated or compromised. But we should not only rely on that, because even the three markers altogether will not give you an idea about the underlying physiology. And then we should check in more details and interpret the blood pressure. So when you look at the blood pressure, we have to understand if the systolic blood pressure dropped, what does that mean? If the both systolic and diastolic dropped, what does that mean? If the pulse pressure narrowed, what does that mean? So we'll understand that eventually during this presentation. If you have echocardiography, it will give you a very helpful parameters and markers to understand more about the underlying physiology. If you have near-field spectroscopy, then you will understand more about the autoregulation and the degree of compensation. So if you integrate everything all together, you'll understand for sure the underlying pathophysiologic mechanism, and you understand the level of compensation so you can formulate at the end your medical recommendation more clearly and on scientific basis. So let us start the actual presentation now after this introduction. And as I reminded you, we have number 4 is the magic number in this presentation. And we need to integrate 4 main parameters: clinical, echo, oxygen indices, and to understand the physiology at the end and formulate medical recommendation. So you have 4 + 1 steps: clinical, echo, oxygen indices, understand what's the underlying physiology, and how to formulate physiologic-based medical recommendation. For clinical, what we need to know, as I mentioned before, you need to know the history in details, gestational age, and we need to know early versus late onset compromised systemic circulation. If the infant is compromised during the postnatal transition, early after birth, or late beyond that level. We understand if there is any evidence of volume losses, perinatal hypoxic insult, or any evidence of infection. Look at the blood pressure. You need to look at all of the parameters in details: systolic, diastolic, mean, and pulse pressure all together. The least important one, the least helpful, is the mean, because the mean is just a calculated number, 2/3 diastolic plus 1/3 systolic. The most important parameter, pulse pressure plus diastolic pressure, if you select 2 of them, because pulse pressure is reflecting the difference between diastolic and systolic. Evidence of anaerobic metabolism, that's very important, and you can get that easily from the blood gases. And if there is any evidence of low urine output, and you need at least 6 hours block to rely on that, excluding the first 12 hours after birth. And if there is any evidence of hypocarbia, and after we started to use more frequently the near-field spectroscopy, we realized that a lot of times the compromised blood flow to the brain is just because of the mechanical ventilation. And if we have infant with low CO2 and left with hypocarbia for a long time. With echocardiography, what we need to know from echo, we need to know if there is any left-right shunt. We need to know the left and right cardiac output, and left and right myocardial performance. If the left heart is contracting, left ventricle contracting well, right ventricle contracting well or not. Systemic vascular resistance, and you need to calculate that, and the calculation is easy. Just we need the mean blood pressure divided by the left ventricle output. And you need to understand that if the filling volume of the heart is good, or there is any evidence of underfilling. And if there is any shunt, and the level of shunt, direction of the shunt. And you need to know that if there is any pulmonary hypertension, is it 2/3 systemic, equal to systemic, or suprasystemic blood pressure? And then oxygen indices. And with oxygen indices, this is only in case of you have near-field spectroscopy. And I know that Dr. Yahya is one of the experts in the Middle East and using and teaching the value of near-field spectroscopy. And you can get a calculation, very easy calculation, which you need to know the difference between the pulse oximetry and the near-field spectroscopy divided by the value from the pulse oximetry. Again, you will get the fractional oxygen extraction, which is reflecting the second level of compensation, which is autoregulation. If you have this number high beyond 0.33, it means that the autoregulation has been lost, because that's the third mechanism after the lost autoregulation is to increase extraction. So if you know that the extraction is already increased, we know for sure that the autoregulation has been exhausted and has been actually compromised. And also you can calculate the oxygen delivery, as we mentioned before. It is 20 to 40 ml per kg per minute. You need the cardiac output from the echo, you need the hemoglobin, and you need the oxygen from the pulse oximetry. And the physiology, now we'll come to the most important part, the 4 categories we mentioned about. We have 4 categories of compensation, or sorry, of hemodynamic physiology. The vasodilator physiology, category number 1. Vasoconstrictor physiology, category number 2, when you have high afterload. And then the cardiogenic shock, which is the most severe one. You have either severe underfilling of the heart, severe pump failure, or severe pulmonary hypertension. affecting the venous return. That's category number 3. And you have the left-right shunt physiology, which is category number 4. Again, we are assuming that the anatomy is normal in this classification of categories, because with the congenital heart disease, we have a totally different classification. And the recommendation should be based on the underlying physiology. So we cannot assume that if the dopamine, dobutamine, epinephrine is fit for everyone. It can be used for everyone. And after we started to use the selective medication, we compared that to our previous empiric approach, was huge difference. And once you started to consider that, you will not go back anyway to the empiric approach. So we have 4 main categories. We have the category number 1, which is a vasopressor. Vasopressors is either one of vasopressin or norepinephrine. And this can be used in category number 1, the vasodilator shock. Echo is not very important because we assuming in this category that the heart is pumping well, you have normal pulse pressure, and the main issue is a vasodilator shock. But if there is no improvement after you start vasopressin and or vasopressor, then you need to evaluate by echo. Inotropes or vasodilator and vasodilator at the same time, like dobutamine or merinone. And this category is better to be used after evaluation by echo, because you have in this category here either the decreased filling of the heart, decreased stroke volume, or also it can be due to impaired heart performance. So you need to differentiate between both by doing echo. And then you have category number 3, or you have the inotrope vasopressor, like dopamine, dobutamine, the dual medication. It's better to be used in category number 3, which is cardiogenic shock. When you have both low systemic vascular resistance, at the same time you have poor myocardial performance. So you need a dual medication to work on both the vascular system and also the heart performance. Dopamine and epinephrine fit for this category. You have to know how to use the fluids and steroids in the right direction, not just to give a fluids blindly, because even fluids can be very harmful on the cardiovascular system. Okay, so let us discuss the first mechanism, or the first category, which is vasodilator physiology. In vasodilator physiology, again, you have the 4 different assessment tools, or 4 steps: clinical, echo, oxygen indices, and then integrate everything by understanding the physiology and how to formulate medical recommendation. In clinical, the vasodilator shock, it can happen at any age, at any stage, can happen in preterm, term infants, can happen early after birth, or can happen late. So it can happen at any time. I'll give you an example. If you look at the monitor, your monitor, and I don't care too much about the blood pressure at single longitudinal time. You need to look at the trend, because some infants, they may have a low blood pressure, and if the blood pressure is plateau and stable without any oligonucleotide or lactic acid, you don't have to do anything. But if you have the trend like here, look at the trend in graph trend, you can realize that the blood pressure is dropping, continuously dropping, and you have 3 lines: diastolic, mean, and systolic, and the red area is the pulse pressure. If you put the cursor at any time, you'll get the 3 numbers, and you can realize the pulse pressure is normal here. So in this category, you have low systole, low diastole, but the pulse pressure is normal, and the pulse pressure again is reflecting that the stroke volume is normal and the heart performance is normal. So the diastolic dropped, and followed by systole, because the heart does not require to contract against low resistance by the same pressure. And sometimes you have also in this category hyperdynamic heart. You might have the heart is really working over a hyperactive to compensate for the low resistance. Again, in this category, you have normal pulse pressure, which is the most important parameter to consider. And if there is evidence of anaerobic metabolism, you have really decompensation, then you are actually late. So you have to detect the case by looking at the trend before development of lactic acidosis. As I mentioned by echocardiography, if you look at the echo, you can realize that the heart is contracting normal, good contraction, good filling. That's a four-chamber view of the heart. You have the left side of the heart. It's a mirror image if you are not really familiar with echo. So for a chamber view of the heart, you have left ventricle, left atrium, right atrium. You have, if you look at the imaginary dot in the middle of the ventricle, you can see all of the walls moving inward and outward, contracting well, and the filling is normal. The filling is a black cavity, which is a blood inside. So the heart is not collapsing at the end of systole. And you have the apex made by left ventricle. So the left ventricle is dominant. You have the right ventricle is contracting normally. And then if you calculate in this situation here, if you calculate the systemic vascular resistance, you will get the equation, which is systemic vascular resistance in this case will be less than normal. The normal is between 150 to 200 millimeter mercury per liter per kg per minute, which is a normal systemic vascular resistance. In this case, you have lower, like you may have maybe less than 100 or less than 50. With the oxygen indices, it is the same as we mentioned before, so we don't have to repeat that again. Look at the difference between the pulse oximetry and near-field spectroscopy, and try to calculate the fractional oxygen extraction. And then the physiology of the category number 1, it is typically vasodilator physiology. So you need to select the medication fit for this category, which we'll mention that later. It is vasopressor. Again, check the blood pressure trends and look at the histograms of the blood pressure, or look at the trend as a graph trend, not just look at the blood pressure at one time. And if you do an echo, it might add a value, like to be sure that there is good heart filling, good contractility, and you may have hyperdynamic heart in this category. Adding near-field spectroscopy, you will understand more about the autoregulation and compensation. And then sometimes if there is no good response, you may need to check the cortisol level, because in a lot of situations you may have someone like infant with the sepsis or septic shock with suprarenal dysfunction, and you may need to give hydrocortisone to improve the vascular resistance in this case. So the recommendation is typically, sorry, with the physiology, I just show you one thing here. With the physiology, if you look at the trend, this infant was given vasopressin as a vasopressor. No, the example will be later. So if you look at the blood pressure variables in this case, you have the blood pressure is the cardiac output multiplied by systemic vascular resistance. In this case, you have the cardiac output slightly increased, but you have significant decrease in systemic vascular resistance reflected on the blood pressure. And the blood pressure here in this equation is the mean blood pressure. So the category number 2, we'll move to a different category, and the approach in this category is totally different, which is a vasoconstrictor physiology, or category number 2. And in this category, it is the most difficult one to diagnose. And why? In this category, if you are relying on mean blood pressure, typically in this case, you have normal mean blood pressure. And you have even higher than normal diastolic and higher than normal mean. This condition is not very common, but should be expected. And it might happen with HIE, hypoxic ischemic encephalopathy. It might happen with post-PD ligation, or it might happen in preterm infant early after birth due to failure of adaptation. So in this category, you have infant with either normal or high resistance, and you have a condition that the heart cannot contract against that resistance. So you have the preterm infant and just born after separation of the placenta, which is vasodilator media, and the heart is not ready enough to compensate for the sudden increased resistance after birth. That's why we call it failure of adaptation. Or we may expect, even in term infants, failure of adaptation with HIE, hypoxic ischemic encephalopathy. Or after PD ligation, because after BD ligation, the resistance suddenly increased and the heart is not really prepared enough to adapt for that sudden increase in resistance and the decrease in volume after ligation of the duct and decrease in the significant decrease in the preload, which already was high before BD ligation. In this case, you have, before we move to echo, we have systolic blood pressure, low or acceptable, but you have normal or high diastolic blood pressure. And definitely you have very narrow pulse pressure. And let me show you that in the graph. Look at the trend here. You have this infant who is stable with normal pulse pressure, as you can see with the 3 lines. And all of a sudden here, the diastolic blood pressure increased and with significant narrowing of the pulse pressure. Look at the pulse pressure is only 7 millimeter mercury. That's very narrow. In this case, if you look at this infant with 34 weaker and mean blood pressure 39, if you relying on mean blood pressure, definitely you will not pick up this case and you will miss it. And that's actually happened in this case, was missed for 12 hours and lactic acid was 11. After a long period of time, no one realized that the pulse pressure was very narrow. If you look at the echocardiography, because the heart is contracting against high resistance, so we may expect that the heart contraction is really poor, as in this case. You can see only valves are moving, but there is no actual movement of the ventricles. So cardiac output in this case was just about 60 ml per kg per minute. The normal cardiac output is between 150 to 300 ml per kg per minute. If you look at the equation of the systemic vascular resistance, it's very expected to have high systemic vascular resistance because in this case you have low cardiac output and you have high mean air pressure. So the end result will be high systemic vascular resistance. It could be 300, 400 higher than normal, which is 150 to 200 millimeter mercury per liter per kg per minute. And again, it is easy to calculate. You need just the mean blood pressure and left ventricle output. The physiology in this case, as we mentioned before, it is increased resistance and the heart cannot compensate for that increased resistance. We don't have to mention that in details, but the recommendation, makes sense recommendation in this case, after echocardiography, is vasodilator with inotropes. Again, the common causes, failure of adaptation, postnatal adaptation, post-BD ligation, post-AV malformation embolization. If you have infant with AV malformation undergoing embolization, that's very common to happen. Or you have pulmonary hypertension. Recommendation in this case, echo is mandatory because you need to assess heart filling, contraction, performance, and calculate systemic vascular resistance. And vasodilator with inotropes, not vasopressor, is a make sense medication in this case. If you start on dopamine of 5 mics as like your own common approach and increase to 10, don't keep increasing the dose up to 20, 30, and the infant is worsening. If the infant is worsening with the increased dose, means that you are going the wrong direction. So you have to revise your approach instead of just to keep increasing the dose or adding more medication. And then the category number 3, which much easier now to understand. It is similar to category number 2, but add on top of that, the resistance already low. So you have poor heart performance, weak heart, and weak or low resistance. In this case, we have everything low. Low systole, low diastole, low mean blood pressure, and narrow pulse pressure. Everything is low and everything is compromised. As you can see here in this blood pressure trend, the blood pressure was normal. This infant was preterm infant 25 weaker after birth. And you can see how the blood pressure all of a sudden narrowed, the pulse pressure narrowed, and everything compromised and everything dropped. So you have decreased in systole, decreased diastole, and very narrow pulse pressure. The blood pressure is almost like one line. Pulse pressure in this, after like the infant started to compromise here is about maybe 5 millimeter mercury or even less. And you can see here after start of low dose of epinephrine, the blood pressure normalized. If you are using the typical medication, the make sense medication with the physiological approach, you don't need to increase the dose to the horrible doses like 20, 30 mics per kg per minute. You will get actually the improvement from the low dose, like 5 mics, 10 mics, maximum 15 mics. And for epinephrine, 0.05, 0.1, 0.15, you should get some response. If there is no good response, you have to check for the suprarenal dysfunction, and you may consider to give hydrocortisone if the cortisol level is already low, because also it is common here to have infant with the compromised suprarenal function. If you look at the echo, it is quite similar to category number 2. So you can realize in this echo here that the heart is not contracting. Heart is very weak. The cardiac output in this infant was about 30, just 30 ml per kg per minute. There is like minimal pericardial effusion here. It's not very important, but the heart is not really contracting. And also you need to calculate for systemic vascular resistance in this case. And systemic vascular resistance is mean blood pressure divided by left ventricle. And in this case, you have also low systemic vascular resistance. So it is like category number 3. It is like combination between the feature of category number 1 and the category number 2. And it makes sense in this case to use a dual medication which working on vascular resistance and heart performance at the same time, which a dual medication like dopamine or epinephrine. And in this category, I prefer to use epinephrine because it's more direct action and is faster in response. Common in this category, common causes: failure of postnatal adaptation, also might happen, pulmonary hypertension, advanced shock. So you have infants started as category number 1, improperly treated, and now progress to advanced shock. And if you wait more time, maybe a few hours, then the end result will be a reversible shock and death. This category also might happen in HIE. So you can now see the overlap of predisposing factors or causes between the 3 categories. So don't assume that in HIE, there's a fixed approach of using dobutamine, for example. Some of our colleagues consider that. You may have category number 1, 2, or 3 in HIE. You may have category number 1, 2, or 3 in postnatal adaptation failure in preterm infants. Recommendation in this case, as I mentioned before, makes sense to use the inotrope with vasoconstrictor effect like norepinephrine or dopamine. And let us now move to category number 4 to save time. Category number 4 is PDA left-right shunt. And it is very easy to understand. There is a lot of controversy around treating the PDA at all or treating by medical and avoid kind of surgical treatment, or treating by surgical if with the medical treatment failed to close the ductus. Again, if you look at the history, you have a preterm infant, and if you look at the blood pressure, you will have a blood pressure with the high systole, low diastole, and wide pulse pressure. And then in this actually model just showing the consequences with the high flow or high volume shunt. You have compromised systemic blood flow and the blood shunted to the pulmonary blood flow. You have a pathophysiology of end organ compromised perfusion, and you have a VQ mismatch. You have IVH neck renal failure might happen as a consequence of PDA left-right shunt, and then the impact is on the pulmonary side respiratory failure. And the outcome might be BVL, which is kind of
5 minutes for the first session.
Sorry?
5 minutes to end the first session.
Yeah, very good. So that's more than enough. Thank you. So you have chronic lung disease on the pulmonary side. So this slide is just showing the consequences of left-right shunt. And I don't have to go through the details of diagnosis. Typically in echocardiography, you will see very dilated left heart, like ballooned left heart, very dilated left ventricle, very dilated left atrium, very dilated pulmonary venous return. The physiology in this case is well understood, and the recommendation typically is to consider like your own guidelines. We have our own guidelines in treating PDA, which might be different because there's a lot of controversy around treating the PDA at all or treating by medication or surgery. In our unit, we are relying mainly on medical management of PDA, and surgical treatment, we have almost one case every couple of years. So that's very rare to be considered. So what's the evidence beyond our approach? We have some articles. You may just feel free to get these articles from PubMed, and you can read more about the evidence behind the integrated approach or the physiological approach. So even for the physiological approach, we are talking about the evidence, and there's evidence supporting that. And after we started to apply the integrated approach, we found significant shorter time to clinical recovery compared to the empiric approach. So shorter time to clinical recovery and much less magnitude of interventions or medication. And the details of the approach is also published in some articles, and you can look at that in PubMed. So that's one of the articles, describe more about the approach and how to integrate between echo, clinical and near spectroscopy, and with some normalized values in preterm infants. So you can look at that. But with the second part of the presentation for the discussion, we have more clarification about the approach. Just to conclude the last slide, I have two main conclusions. Consider evidence-based practice if there is high quality of evidence and a clear answer from evidence. Consider physiology-oriented approach for complex pathophysiological conditions like hemodynamics. Because as I mentioned, as I described during the presentation, you have totally heterogeneous situations, and you cannot consider just one line of management to fit with everyone. That's impossible. Understanding the physiologic category of hemodynamics instability and the degree of compensation is crucial to formulate a scientific recommendation. Thank you very much. I'm done with the first presentation. And either we can have the questions after the break at the end, or we may have some questions now. Up to you, Dr. Yahya. Dr. Yahya, would you like to have the break and then case scenarios and the discussion at the end?
Oops.
Dr. Yahya, you were mute. Can you please repeat what?
No, I'm not mute. Do you hear me?
Yes, we can hear you now.
Yes. Okay. So I would allow a few questions, Dr. Yasser, if you don't mind.
Yeah, my pleasure.
Because I think the cases will depend on the first presentation. So if somebody has a question, quick question, can I ask you if you are not tired? If you want to break?
No, I'm okay, no problem. And then we can maybe give a 10 minutes break and come back to the second presentation.
So I do have a couple of questions. I will ask you only one, and I leave the board to others. So my question is for the fraction of oxygen extraction. I guess you are calculating for the cerebral, not the somatic, because the somatic is with the auto-regulation, it will be of no point. So right, is that correct or not?
Yeah, exactly. So yeah, that's very important question and the clarification at the same time. So the number that I mentioned is like mainly focusing on the brain. For the somatic, sometimes we consider abdominal or intestinal fractional oxygen extraction if we are suspecting necrotizing tuberculosis, which is a different situation. But for compromised blood flow, or shock, we are considering the cerebral, which is the most important organ in the body for sure, to consider the fractional oxygen extraction and as said, the autoregulation. So I'm talking mainly about the cerebral, because the somatic is totally different. And even the numbers for the kidney, abdomen, like the numbers are different.
Yeah. And for the epinephrine, you are using it for category 3. Is that correct?
Yes, if you have like collapsed circulation with everything low, like all of the blood pressure parameters.
So my question is, how common you use epinephrine? Let's say in a year or in a month, like how common use of epinephrine in treating shock or category 3? How common category 3 occurs in your experience?
Yeah, that's very good question. So if you consider what is the most frequent, like to arrange them, what's the most frequent one with our experience? So category number 1, which is vasodilator shock, is the most common category. And almost, you can consider maybe 90% of the premature infants beyond the postnatal transition, they are belonging to this category. So the most common actually medication used is the vasopressors, to be honest. Either vasopressin or norepinephrine, the most common one.
Same. So I do same. Alhamdulillah.
Yeah.
So a question from Talat is asking you, can you please ask what is he preferred treatment for 22 to 24 weeks babies? Should hydrocortisone be considered early? Thank you. I'm not sure he meant
Yeah.
in the, or I don't know. So you have the floor. You can answer.
Yeah, thank you very much. Actually, there's many approaches for hydrocortisone early. So there is actually a very interesting randomized controlled trials, I think published last year, about prophylactic early hydrocortisone with ignoring what is the cortisol level or suprarenal function. So they are considering that for infants less than 27 weeks and above 22 weeks, soon after birth for 1 week. And they are starting that as a prophylactic. And the outcome of the study showed that with the hydrocortisone increased the incidence of survival at the time of discharge with less chronic lung disease. So the end result of the vascular trial was positive. There's a different approach, which is using a targeted hydrocortisone if you have evidence of suprarenal dysfunction. For example, if you have a preterm infant who's compromised the blood flow, or like hypotension or severe hypoxemia, and requiring high setting of ventilation or so, and you evaluated the cortisol level for suprarenal functions, and the cortisol level roughly in the literature is about 300 and sometimes more for 400 millimole per liter in stressed infant. If you have like low cortisol level, can be even 30 or 40 sometimes with our experience, then it's better to consider that as a kind of rescue management or targeted management for those preterm infants with compromised systemic circulation or respiratory system. So there is two different approaches. One supported by physiology and the other one supported by evidence.
Okay. So it seems that the hydrocortisone is the man of the show because lots of questions on the hydrocortisone. So Dr. Ahmed Abul Fath Salim asking you, can we start hydrocortisone even if the serum cortisol level is high, especially in the first few days of life? And I think you answered around the questions.
Yeah, if you are considering that as a prophylactic, because again, there is a limitation for the level. There is a circadian rhythm with the cortisol. If you check it at one time, it is not really the gold standard to rely on that, because if you check it 12 hours later, it can be a totally different number. So like there is a lot of limitation to get the number. It might be helpful, but not always. So if you are considered a prophylactic, you don't have to do a level. Just do it for any preterm infants if you have that acceptable protocol in your unit. But if you are using it as a targeted management, that's a different scenario because you are using that for already compromised infant. And again, we are considering that if the level is low. To get a true low one, you need to do ACTH simulation test, which is really difficult and not practical to be done in preterm infant.
Okay. Dr. Arul Azir asking you, hydrocortisone role, is it in refractory hypotension or in adrenal insufficiency cases?
That's a very good question. So if you have a refractory, again, I prefer to avoid using hypotension, because now if you have seen, and when we describe the 4 categories, you have category number 2, you may have even high blood pressure, but you have very narrow pulse pressure. So I prefer to use compromised blood flow or compromised systemic circulation or hemodynamic instability, because it could be with even high blood pressure. But if you consider like compromised blood flow up to the level of shock or before even the level of shock, refractory, it can be due to different reasons. It could be because of suprarenal dysfunction. But if you have a cortisol level of 1,000 or really high, I don't think that there is a role of hydrocortisone in that case. But it could be because of the medication that we are using, which is very common if you are using a wrong medication. Or it could be underlying cause like abnormal filling. There is no good filling of the heart, which we need to assess by echo. So the unresponsiveness, it can be due to different reasons, not only the suprarenal dysfunction. So only consider if you have someone with a low cortisol level. If you have really high cortisol, if you are in doubt, you can repeat it in 12 hours. Because if you have consistent high cortisol level, even after 12 hours, then I don't think there is a rule for to use hydrocortisone in this case. Just to try to sort out the reason for unresponsiveness, and there is many reasons for that.
Okay, thank you for the answer. So this is a question, I think it's hard to answer in a short period, but Dr. Ala Ubaid is asking you, what is your protocol for the management of the PDA ligation? Like, I mean, he meant, what is the
indication? Yeah, the indication, that's a very good question. So almost 7 years ago, and I think when you were in Canada, you may remember that very well, Yahya. When we were relying mainly on our colleagues from, respected colleagues from cardiology to consider PDA, just ignoring the PDA shunt significance or the clinical significance, after failure of medical treatment concerning PDA ligation, we had almost 15 cases every year. In about 2 hospitals, we have about 20,000 deliveries every year. And then after we shifted to the targeted echocardiography approach by relying on the neonatologist trend in echo, we started to have more conservative approach in PDA ligation. And almost all of these cases that we are considering for ligation, the PDA eventually closes before discharge. Mm-hmm. The only case that we found that we should consider ligation or we should evaluate for ligation when there is a renal failure. So you have significant oliguria or anuria, and there is no improvement in urine output by any means. You tested the cortisol level, given hydrocortisone, given all of the medications, and you have increasing creatinine, worsening kidney functions, and there is no other reason other than the PDA. So you have a reversible diastolic flow in the renal artery, and you have significant left-right shunt. There is no any other explanation for the worsening kidney function. That could be the clear indication for PDA ligation. There's a rare scenario. So how many cases over the last 6 years? We had about maybe 3 cases in 6 years. That's not really a common scenario. And after ligating the ductus within 6 hours from the PDA ligation, urine output improved, which was indicating that the ligation was the right decision in those cases.
Mm-hmm. Thank you for the answer. I can tell you that I'm struggling for the PDA, lots of ligation. So there is a Dr. Ving Ping Dang, and my apology if I pronounced your name incorrect. So he's asking you, clinically, we encounter some cases with underfilling heart caused by ventilation. What category does it fit, and how to analyze it clinically and by targeted neonatal echo?
Yeah, that's very good question. Okay, very good question. So this actually will belong to category number 2, and I will tell you why. Category number 2, you have normal diastolic blood pressure, so or even sometimes higher, and you have decreased stroke volume and decreased venous return. In this situation, you have normal diastole and narrow pulse pressure. because again, the pulse pressure will be reflecting the stroke volume and the myocardial contractility. In this case, you have underfilling because of the high mean air pressure. And you just look at the blood pressure trend, you will notice that the pulse pressure is narrowing. Once you release the pressure or you decrease the pressure, the mean air pressure by 1 or 2, you can, even without echo, you can realize that the pulse pressure is widening, and which is reflecting that the venous return improved. The best way to diagnose this condition is to do echo and decrease the pressure and watch the pulmonary venous return filling, which is very sensitive to increased mean air pressure, because the pulmonary veins are entirely within the chest and subjected to the mediastinal pressure. The systemic veins is connection between the outside pressure and the inside pressure in the mediastinum. So look at the pulmonary veins, which they are entirely within the chest cavity, and you need some experience. You need to how to look at the pulmonary veins and to detect the flow by Doppler. But simply, you will have in this category number 2 and narrowing of the pulse pressure.
So, Dr. Yasser, you don't look to the collapsibility of the inferior vena cava?
Unfortunately, it's not very reliable in neonates, because very subjected to a lot of factors, including mechanical ventilation and the mode of ventilation. So, to be honest, I'm relying more in the pulmonary venous return, because pulmonary venous return Doppler, it is entirely within the chest cavity, as I mentioned, and is very sensitive to the increased mean air pressure. And also, you look at the left ventricle and the diastolic volume. Mm-hmm. So the collapsing sign or the kissing sign, when you see the posterior wall, the ventricle touching the septum, and they have actually echo for that in the one of the case scenarios. When you see the septum touching the ventricle wall, means that the end systolic volume is very low. So you need to release the pressure or to give more volume or to treat the condition.
Okay, Dr. Tariq Qutb, thank you, Dr. Yasser. Dr. Tariq Qutb is asking you, if we start epinephrine in category 1, I don't know why you start epinephrine category 1, but anyhow, if we start epinephrine category 1, vasopressor dose, and patient on the same time develop tachycardia function, is it okay? What we will do?
Yeah, in category 1, I never use epinephrine for category 1.
Me too.
Yeah.
I don't use epinephrine.
Yeah, so because in the problem is with epinephrine, which is like a medication with a lot of side effects, including you may have decreased tissue perfusion sometimes if you use it actually inappropriately, or if it is not indicated to be used, you may have increased lactic acid and you may have other issues that you probably is better to avoid.
So, giving epinephrine to this patient is as if giving, asking somebody on wheelchair to climb a mountain. I mean, I don't know why you want.
So it is not really the appropriate management. Either to use low dose of dopamine if you are not really comfortable to use vasopressor.
Very good.
But the maximum 10 mics. If you are exceeding 10 mics and there is no improvement, it's better to shift to vasopressor.
Okay. The question is from Muna 23. I don't know how to pronounce that. So the question is, when you use vasopressin, I think he answered that during the question. He said category number 1. But the question is when you use vasopressin and when the question is when you use vasopressin.
Okay, so as a vasopressors, we have 2 common vasopressors in use: vasopressin and norepinephrine. There is no preference between both unless you have pulmonary hypertension. So you have someone with increased pulmonary pressure, vasopressin might help in actually improving the venous return to the right atrium with high pressure, because it is vasopressor at the same time it is venopressor, so it is squeezing the venous return to the right atrium to improve the filling in pulmonary hypertension. So if you don't have pulmonary hypertension, there is no preference between both. Just keep in mind that vasopressin, there's some side effects. For example, if you have hyponatremia, low sodium, serum sodium, it's better to avoid vasopressin. So you have sodium in 120s, like less than 130. It's better to avoid vasopressin. If you have someone with renal dysfunction or so, maybe it's better also to avoid vasopressin. But anuria or oliguria is not a contraindication for vasopressin, as far as anuria is because of the low blood flow, because the vasopressin is a renal vasodilator. So it is expected to improve the renal perfusion in this case.
Yeah, I actually do the same as you mentioned.
Yeah, very good. Yeah, I'm sure.
Bing Ping Dang ask you, and please apologize if I did not pronounce your name correctly. Asking you, can we have a PDF copy of this presentation?
Yeah, unfortunately, this is not actually a PowerPoint. So there's a software, which is a Smart Builder software, which you need to subscribe for the software. It's really expensive, very expensive. And you need to have the software to give you, to be able to watch the presentation on it. So unfortunately, it is not a PowerPoint, but we can maybe share the PDF of the description of everything in a kind of PDF format, and instead of having just the slides. And you may have even more description in that format. So I have a small booklet, so we can share it with
anything you provide me, I will share.
Yeah, for sure.
Okay. Dr. Sundus Khudr asking you, what is a clinical example of vasodilator shock?
Yeah, that's very common example to happen in any preterm infant with septic shock. That's the most common example. Or preterm with NEC, or preterm with systemic inflammatory response syndrome. Preterm with late onset hypotension. Sometimes you may have preterm with no sepsis, but like a few weeks after birth, develop hypotension with no evidence of infection. In this category, you need to check the cortisol level. Could be suprarenal dysfunction, because the vascular tone is very sensitive to the circulating cortisone. You may have that in HIE. You may have also the vasodilator shock, iatrogenic. Like if you are infusing too much morphine or vasodilator medication, or post anesthesia. Someone came from OR after anesthesia and he got a lot of morphine or fentanyl that might, and the morphine is more than fentanyl, that might cause more hypotension. So you need in this situation to wean the medication and also to support with the vasopressor.
Yeah. So I will give you 4 minutes break and we'll resume at 9:15. I don't know what's the time in yours. So we'll give you a few minutes.
It is 12 my time. So probably, 5 minutes or 7 minutes, and then we'll come back.
Okay. We'll come back. Great.
Yeah.
Okay.
Thank you very much. Thank you, everyone.
I'm going to answer Tariq. Tariq, epinephrine is using it when there is both. You have a failure of the heart and failure of the systemic resistance. So everything is failing, and that's the indication of epinephrine. And it's a category number 3, if you remember. Because in category number 2, you have high systemic. So when you have category number 3, you might think of norepinephrine. And you have to have very good hemodynamic assessment when you decide to do that. It's very rarely used. It's not a common use, but it's in category number 3 when you use the epinephrine. Hadi is... in scenario 3, will you use inotropic? Yeah, you can use, Dr. Hadi, you can use both. One increase contractility and one cause vasopressor. It depends on which one is available, which one is more severe from the cardiac failure and the peripheral vascular resistance. But you can use both. You can start at the same time. You can also start one after another. This depends on the, you have to individualize the scenario. Okay. So I'm going to mute myself. I'm gonna go drink water and come back. we'll start in a bit the second scenario. Dr. Yasser, should I ask to start the polling or not yet?
No, I will let you know because we I'll start with the description, but the first one should be ready. Yeah, you can maybe yeah. Let me just
yeah, take your time.
Start.
Take your time.
Yeah, maybe 1 minute and then.
Okay, take your time.
Okay, should we start?
Yeah, please go ahead.
Okay, so we have the first case scenario, and just I will show you in the case scenario, if you look at the blood pressure, like how much, like the limitation would be when you just look at the clinical presentation and the blood pressure as just one longitudinal assessment for the numbers. And if you look at only the mean blood pressure, will be even more limited, and you will not get any clear inside idea about what's going on. So I have the first case scenario, and both case scenarios are the real cases from our unit. The first one, I will ask you a question, and Dr. Yahya will just show the selection, and please select one of the answers. So we have a preterm infant born at 25 weeks gestational age, and now he's 34 weeks corrected, or post-menstrual age of 34 weeks. Birth weight was 620 at birth. His clinical course was complicated with a lot of complications related to prematurity, but just I will focus on he developed a neck, stage 3, and recovered. And after that, he developed intestinal obstruction with a lot of residue and a lot of fluid losses, and required ileal resection with ileostomy. So he now went to OR for ileal resection with ileostomy and came back sick. And when he came back post-operative, and just focus now on this part of the scenario, he came back from OR anuric with normal mean blood pressure, as you can see here, like 41, the mean blood pressure, and significant edema due to third space losses. So initially, our colleagues consulted the nephrologist who recommended Lasix. So you have the blood pressure as you can see here. And the first question, diuretics with or without albumin can be considered first. So you have 3 options. So can you select one of the options as you can see on the polls?
So should I put them the poll now?
Yes. So the first question, you have either to use diuretics or to use inotropes should be added in this condition, or you can say, I don't know, and I need more assessment, or I need more help.
So you guys can poll now. You can select for first question. Please go to the polling and answer the first question. The first question, not the second, please. The first question. Leave the second question. Just answer the first question. Please do not answer the second question.
Yeah, only the first one.
Please answer the first question.
If they already answered, they cannot change. So probably just focus on the first, and then we'll offer the second question again. So anyway, I think we have now, maybe you can close the
Okay.
polls.
So you have about 63% for the third question, and you have 1% for the first answer, and you have 21% for the second.
Okay.
Okay, Torias.
So I'll end the poll. So you have, like most of you, maybe 2/3, answer the third option. I need to do more details, which is good. So I think now we got the lesson correctly. So we can share the results, and then maybe close it.
Okay.
So if you select the third, if you select the first option, what will happen? The diuretics, yes, it can be used. And the system will direct you to the system. There's actually a clinical support system. So if you select the first one, the system will let you know that it should not be considered based on the blood pressure values, as maybe you missed that the pulse pressure was narrow. And that might reflect poor myocardial performance or underfilling. So you have to go back and select another answer. So I'll shift you to go back. So look at the blood pressure here. You have systolic of 46, and you have diastolic of 39 or almost 40. You have only 7 pulse pressure. So for infant with his corrected age of 34 weeks, so he's almost 9 weeks after birth, the pulse pressure should be more than 20 millimeter mercury. So you have very narrow pulse pressure here. This could be due to underfilling, poor underfilling, or could be due to poor myocardial performance. So you cannot use diuretics for someone with empty heart. Diuretics is dangerous to be used when you have underfilling of the circulation. In troops, the same. If it could be due to underfilling or could be due to poor myocardial performance. In this situation, inotropes should not be added, because if you add inotropes on top of empty heart, you will worsen the underfilling. So inotropes might improve the systolic performance on expense of the diastolic filling. So we need more assessment, and more assessment. Let us analyze the blood pressure in more details. So there is a calculator that can help you to understand more about the physiology. It is like a simple slide in front of you, but behind the slide, there is a very complex engine with integrated with a lot of calculations to help you to understand the physiology. And the engine is already fed with all of the centile curves for the blood pressure. So the infant was late after birth, was not early after birth, 34 weeks corrected. Systolic blood pressure was 46. The systolic blood pressure was 39, if you remember, and mean blood pressure was 41. And the calculator will calculate for you the pulse pressure, and will ask you, is there lactic acidosis more than 3? In this case was no, but the oliguria was significant, so you can say yes. And now you can calculate and see what will happen. The calculator will give you the analysis of all of the blood pressure parameters. So systolic was low compared to this gestational age. Low systolic on top of normal diastolic, and we have very narrow pulse pressure. This category number 2, vasoconstrictive physiology. And now continue to the next level. That's not enough, because we need to assess what was the blood pressure when this infant was stable. We need to understand about the worsening of the blood pressure before and after intervention, which was the OR. So before this infant went to the OR, the blood pressure was systolic of 56, the diastolic of 42, and mean of 47. Pulse pressure was 14, which is also low in this case. And when you calculate, even before going to the OR, this infant was suffering from vasoconstrictive physiology. Now, and it's clinically significant. Why clinically significant? You have oliguria, and you have significant difference between the blood pressure when the infant was stable, and now when the infant after the procedure or sometime after. So you have significant drop of blood pressure or significant narrowing more of the pulse pressure. Clinically significant because you have, if you have either oliguria or lactic acidosis, it is significant decompensation. So in this case, like the question, why this infant was even with the vasoconstrictive physiology, even before this infant went to the OR. This infant with the significant volume losses from the GI and was under compensated for the fluid losses. Remember that the diastolic blood pressure is 2 components, the resistance and the filling. So if you have someone with the low filling, the body will compensate by increasing resistance to maintain the blood pressure normal. So our body will compensate with the dehydration by increasing the resistance. Otherwise, the shock will be very fast and the compensation will be significant. That's why this infant was dehydrated even before OR. So let us go to the echocardiography, and then we did an echo. So another layer of assessment, because that's not enough. Now, should I give fluids or should I give, or should I give any troops to support the heart performance? So we should know that. Sorry, I have.
Okay, it's okay. Take your time.
Yeah. So shift to the echo. So when you look at the echocardiography, now we realize more about the underfilling of the heart. I will just show you one image instead of just going through the details of the echo. The software is heavy, so that's why it's a little bit slow.
You need a heavy computer, probably.
Yeah, you're right. Yeah, the computer is really overloaded.
Yeah. It's very interesting, so we can wait. That's okay.
Okay, thanks. Yeah, just take a few seconds more.
That's okay.
And also making heavy because of a lot of video clips for the echo.
Yeah.
A lot of treasures, Doctor.
Thank you, Dr. Mustafa. Yeah, nice to see you here.
الله يجزيك خير يا
حبيبي مصطفى، انت في كل خير موجود يا دكتور مصطفى.
الله يبارك فيك، الله يبارك فيك يا باشا، ربنا يعزك.
So now we have the echo, and in this software we have divided into the most important views: the apical views, parasternal views, and short axis parasternal, dectal views, and subcostal. So I'll just, maybe to save time, I will show you the parasternal long axis view. And when you look at the parasternal long axis view here in the video, now you can realize that, again, it's slow. The left ventricle is actually collapsed. The heart is really very small, and the ventricle is almost empty at the end of systole. Can you see that, Dr. Yahya?
Yes,
so
yes.
I can only see the tissues. The heart is really very small, and the heart is empty. It was actually Cervaret, this infant was actually alive at the time.
Yeah.
A very small volume, stayed in the heart, in the ventricle at the end of systole. So if you give any troop to this infant, you will compromise more the filling, because any troop like epinephrine or dobutamine will worsen the filling, the diastolic filling more. So this infant should not be giving any troops. And then when we move to the analysis of the echo in the next step, to save time. So in this actually table, I assume that we did the echo in details and we did all of the calculations, and I will just now calculate with you, or go over the report. So that's the echo report that we use in this system. The cardiac output calculated because of the really very small stroke volume was very low. So it was 90 ml per kg per minute, normal again between 150 to 300. Right cardiac output was 105 in this case. And we have LV performance was like good, but we have significant reduced LV left ventricle filling. And to be honest, if you have reduced filling, you should not comment on the performance. BDA size was, in this case, was small and was actually minimal flow, and RV performance was good. Pulmonary hypertension was like, there is no pulmonary hypertension, it was normal pulmonary artery pressure. And the calculator will calculate for you the systemic vascular resistance. Because we did not start, so it is not zero, no, sorry. So because we interrupted the system, it is actually 350 in this case.
Okay, that's better.
So it was very high. Because we interrupted the system, we stopped in the middle. So the system will ask you here, do echo results match the clinical category? In this case, I would say yes, with understanding of the physiology.
Yes.
And if you go to the consideration page, you will get like by default the category number 2, because we interrupted the system. But like once you move to the category, the system will give you the category number 2, but will not let you know exactly what you need to do, because you have multiple issues can be contributing to this category. In this case, we have low preload. Low preload can be due to high mineral pressure, or can be due to iatrogenic, or can be due to severe dehydration, like in this case, or pulmonary hypertension, post-AV malformation, post-PD ligation, or failure of postnatal adaptation. So any one of them, you need to put the clinical scenario and the echo in the context of the case. Recommendation, echo is mandatory. And I think now you realize without echo, you could not actually realize what exactly the issue. And you may continue with giving Lasix, albumin, and the infant might die from severe underfilling of the heart.
Yeah.
So in this case, the most makes sense intervention here to give fluids. Fluid should be considered with evidence of low preload. So number 3, you need to select the intervention consistent with the physiology in this case. And then we'll go to the final report. The final report will let you know, will just extract everything from the previous assessment, clinical, blood pressure, echo, and everything. And you need to enter the patient details here, and you can print it or you can extract it as PDF.
Okay. How much this software cost, Yasser?
It costs so far with the subscription and the manpower, probably close to $5,000.
One time, or like this is yearly?
The subscription is $2,000 per year, subscription to the program, but to develop subscription just to have the program.
Ben gerçekten ta dikkat etmeyen şeyler efendim.
İşte bilirim ben de garip sonradan bir kere baktım yalandan çıkıp karardı başta.
O indi kaydı bu uzaktı.
Yeah, so sorry, can you speak English please? We cannot understand what you're talking about.
No, I think he's talking with his friend. He's not talking.
Okay. Okay, anyway, now we need to know what is the decision in this case. But we are not actually selling the software for $5,000, to be honest. Yeah. So we will offer this software on our website and for the members to approach. So that's a cost from our side, but we're not selling for the people to buy it for $5,000. That's too much. We'll just offer it for the members of POCUS New in the website. Once you apply for a membership later, and once we validate, we need to validate to be sure that the software is working properly, then we offer it and everyone can get a copy and can use it. Okay? Yeah.
Sounds good.
So I have the second question now. So what would be your recommendation after the integrated assessment? I think it's easy now. So select one of the answers. It was the second question that I think you tried to answer.
I will poll again. Please answer the...
Number 2.
Number 2.
Yeah.
So answer number 2, please, again. Even if you answered before, answer number 2. Only number 2, not number 1.
Okay. So almost started with the significant. Okay, we'll just wait until the end.
Okay. Not number 1, only number 2. Not number 1. Only question number 2.
Okay, I think that's enough.
Okay, so you have about 22% for the third answer, and you have we have 55% for the third answer, and you have 35% for the first answer, and you have 4% for the second answer.
Very good. So let us analyze now the 3 options. Fluids with inotropes. Again, we said inotropes should not be used in this case because you don't have typical issue with the myocardial performance. You have underfilling of the heart. And again, inotropes, if you use inotropes, it will worsen the filling of the heart further. So it should be avoided. And remember that inotropes for dobutamine, there is a vasodilator effect. The body is compensating. The body is smart to compensate by vasoconstriction and increase resistance. So actually you will decrease the level of compensation by adding vasodilator. Okay. And if you select the diuretics in this situation, you can only use diuretics after refilling of the tank. Don't use diuretics on empty tank because you will compromise the renal function more. And this infant was already on diuretics for 1 day with worsening
Yes. Okay.
of the condition. So you need to fill the tank, and you need to repeat the echo. Be sure that the heart is full enough, and then no problem. You can start to use diuretics even as a continuous Lasix, with or without albumin after that.
So
Remember,
was he edematous because he has hypoalbuminemia, or because it's capillary leak syndrome, or what? Why he was edematous?
because of both, like because of the capillary leak post-operative inflammatory process, and also because of albumin was very low. I think was maybe 14 or so.
Oh, okay,
but
okay.
the problem, if you give albumin with infant with capillary leak syndrome, the potential for the albumin to stay in the circulation is very low. So the albumin will leak in the third space, will drag the water to the third space, and will aggravate the edema. So it's better to wait until you control the capillary leak. And it usually takes about 2 to 3 days post-operative, and until you have the markers of inflammation subside, like low CRP. And also you may consider steroids in this situation to improve the capillary leak syndrome, which we did in this case.
Okay.
So typically we use the fluids in this case. And just to summarize the lessons from this case, so after we apply the integrated evaluation of hemodynamics, there's a case of capillary leak syndrome with third space losses, low cardiac output compensated with high vascular resistance. Again, the calculated vascular resistance was about 350. And compromised autoregulation with high functional or fractional oxygen extraction. I did not show the NIRS because, like, I believe NIRS is not really available everywhere in the Middle East yet. But when we evaluated the autoregulation, the near field spectroscopy reading for the brain was about 45%.
Oh, wow.
And the calculated total oxygen delivery because of low cardiac output was low in this case. So we have like significantly compromised infant just one step before development of lactic acidosis. So lactic acid was not high in this case, but we just catch it up the case before development of lactic acidosis and significant decompensation.
What is the maximum in this gestation, the maximum fraction of oxygen extraction that the baby can achieve in this gestation?
Yeah, with my experience, I think the highest number that I saw is like in 50s, like 55 or so.
Oh, okay.
And in literature, I don't think beyond 60 is can be achieved. Any infant can tolerate, can adapt to, say, once you reach maybe in 50s, then you will have the lactic acidosis after that.
Yeah.
And once you have lactic acidosis, you cannot really rely on the NIRS anymore. The NIRS is more helpful during the period of aerobic metabolism. Once we have anaerobic metabolism, the tissue will not extract anymore. The tissue will be very sick and will not extract, and will have tissue damage, and even the number will be normalized on the NIRS, or even will be high.
Oh, okay, okay.
So formulated medical recommendation, fluid management guided by echo. We did that. Monitoring autoregulation and the cerebral oxygen by NIRS. Also, we did that if you have NIRS available. Steroids might help to improve capillary leak syndrome. Also, we know that. Vasopressor and inotropes should be avoided in this case. Again, vasopressors are body already at the maximum of increased vascular resistance, so there is no point giving pressors. Inotropes will worsen filling of the heart and should be avoided. Diuretics with or without albumin can be used after restoration of the vascular volume. So it is not really a physiologic makes sense idea to use diuretics on empty tank. You have to fill the tank, you have to fill the heart, and it took about maybe 3 days for this infant to get the urine output improved and the heart to be full. And I'm quite sure if this infant not properly managed with the good volume expansion, this infant would actually die within a short period of time. Any question about this case?
Amazing, yeah.
Yeah, thank you.
Beautiful, beautiful explanation. And sometimes we do the same, but we cannot exactly explain it because, you know, the tools are not available.
Yeah.
But it's very good and very clear. Thank you very much.
Thank you.
And
So
everybody,
if
thank you.
Yeah, if anyone would like to text any question, let me text
Yeah.
to Dr. Yahya or let me know.
Yeah.
And again, remember this actually checklist, which we show it in the first presentation. If we check whatever available or whatever applies in this case, we have hypovolemia, and it was true volume loss. We have high afterload vasoconstrictive physiology. In this case, was a compensatory mechanism, was not the true physiology. The true physiology here was hypovolemia. And vasoconstrictive physiology from the blood pressure was a compensatory mechanism. And we understood that only after we did the echo. We have compromised co-regulation by NIRS and also low oxygen delivery after we applied the oxygen delivery equation.
So, doctor, we will give the fluid challenge, and then we will not go for the Lasix because the child baby is already with the
Why don't you,
oliguria.
sorry, doctor, why don't write your questions, and then when we allow you to talk, we can do that.
Yeah.
Okay.
Yeah, thank you very much. Like anyway, again, you should not give Lasix an empty tank. And again, in this case, was really helpful to understand that, but because they considered that before we started the fluids. Lasix was given infusion to a dose, like a very high dose. I think was up to 5 milligram per kg per day infusion dose, and was not really effective. And it might be even harmful more. So it should be.
Sorry, do you want to take a question now or later?
Probably after the second case,
okay.
To just give a chance to discuss the second case.
Okay.
So let us see the second case, which is another challenging case, and like a different physiology. So we have a preterm infant, male infant born at 25 weeks, gestational age 8 hours of birth, and birth weight 620 grams. And when you look at the monitor with me and consider what could be the intervention, you have a blood pressure 29/18. Remember, it 25 weeks, gestational age, 8 hours old, first day of life. And you have systolic 29/18, mean of 23. And 4 hours before that, the blood pressure was 41, 26/35. Lactic acid was 2.7. Again, look at the monitor, and you may realize something different. And please select appropriate intervention. Now, question number 3. And only answer, please, the question number 3. So you select intervention.
I made it question number 1 for case number 2.
Okay.
So, okay, sorry. Should I start?
Yeah, sure. So no intervention needed or vasopressor, or more details needed, or IV fluid bolus, based on whatever you have now.
Please answer the first question only.
Only the first question. Yes.
Answer the first question if you want. Nobody answers so far. People are confused probably.
Yeah, answer the first question. Yeah, now you started.
Okay.
Okay. So we have 100%, but only we have three participated, 3 voted.
Only 3 participated. So please participate. Please participate.
Yeah.
Do not text. You don't need to text. Just answer the question.
Yeah, select on the on your screen.
Just select on your screen the answer. Okay. If it's difficult, just leave it. You will know the answer later. For me, it's not difficult. I can tell you the answer.
Yeah, I know. Yeah.
I will have privilege to work with Yasser, so probably I know all this.
Yeah, that was like my great pleasure. And we are missing you, Yahya.
Allah barik fik, Allah barik fik, Allah barik fik. So please answer question. No need to, I don't know why it's not working, Dr. Dua. I'm not sure. It's a polling, it should reach you. You are inside, it should reach you.
Or yeah, look, like if you're on the cell phone, look at the bottom of the screen. If you're in the computer, just adjust your screen to be able to see that on the right side of the screen.
Oh, okay. I don't know
You
why.
need to expand the chatting window.
Submit at the end, it can be. When you want to submit, it would be at the end, at the bottom of the, if you're using only your mobile. People, they have difficulty. I don't know why there is a difficulty to submit.
But anyway, yeah, I think maybe that's enough now, just to save time.
So
we have, yeah.
We're ending the polling. So you have 64% to number 3, and only 27% to number 1, and 0% to number 2, and 9% to number 4.
Okay. Okay, so let us now discuss the options.
So
No intervention.
I think they're confused.
Yeah, no problem. We'll discuss the option one by one. So option number 1, no intervention needed. If you have the same type of monitor in your unit, the bedside nurse was very smart, and she came to us and she said that look at the trend of the blood pressure waves. So you have the blood pressure arterial line here, and you have abnormal waves. She thought that could be technical issue. She adjusted the line many times, and still you have the same issue. So that's actually abnormal. That's pulses alternans. So you have when you have weak pulse alternating with strong one, weak and strong. So that's abnormal. When you have someone with the cardiovascular instability or weak heart, you have pulses alternans. So that's the first thing that draw our attention. This infant is compromised. Mm-hmm. When you look at the blood pressure, let us analyze that on the calculator, because when you look at the numbers, you may get confused, or you may get false interpretation that the numbers could be abnormal. Vasopressors should be started. There is no indication for vasopressor in this situation, and I will let you know why. More detail, for sure, we need more details. IV fluid, what's the evidence of volume loss here? We don't have evidence for volume loss to consider IV fluid. So consider option number 3. We need more details, and we need to analyze this case in more details. So this infant was early after birth, and the calculator actually will understand the difference between postnatal transition, because there is a special centile curve for postnatal transition and the different centile curve for beyond postnatal transition. And the calculator will understand that you need just to select early or late. 25 weeks, and you have systolic blood pressure of 29, diastolic of 18, and mean blood pressure of 23. And the lactic acid was with the normal. We consider more than 3 as abnormal. In this case, oliguria, more than 6 hours. This infant was only 8 hours old. We cannot rely on urine output in this case. So calculate, you will get everything acceptable. So now you have everything acceptable, and there is no impression from physiology. But I have impression this infant is compromised. Why? What's the reason for pulses alternans? So we need to continue in this case and ask the calculator, what's your impression when we enter the blood pressure just 4 hours before. In the blood pressure, the most important parameter is the trend of the blood pressure. One parameter, longitudinal parameter, is not really helpful at all. You need to look at the blood pressure over time and look at the trend. And the trend, you can look at the trend as graphs or as a table, and you can get that from any kind of new available monitor. All of the new monitors in the market, they have all kind of trends that you can look at. So the blood pressure before, a few hours before, was 41 systolic and 26 diastolic, mean of 35. And now calculate, we'll see what will happen. So we have acceptable, for sure the blood pressure is very good, but clinically significant what? Clinically significant dropping or worsening of blood pressure over time. So the calculator will calculate the difference between the blood pressure over time. If the drop of blood pressure more than 20% over 2 timelines, we'll consider that as clinically significant. But how to treat? Now the calculator just calculated the blood pressure difference and is clinically significant. I have issue now, the blood pressure is dropping. What I should consider now? IV fluid, any troops, vasopressor. Now there is something going on wrong, and this infant will be more compromised if we wait more time. And just this example will show you how how much limitation you will encounter if you are only relying on clinical parameters, even with the trend of blood pressure, even with the detailed blood pressure, systolic, diastolic, and everything without echo. Then I will show you the echocardiography. And the echocardiography, I have more like images to look at. I have the fourth chamber view. And fourth chamber view, you can realize that the heart is contracting fast because of the tachycardia, but there is no effective contraction. So you'll get false impression of hyperdynamic heart, but you will realize that the heart is not really working properly once you calculate the cardiac output. And if you look at the cavity here, it is almost empty. But if you look at the parasternal long axis view, you can realize that the cavity is almost empty as well. So you can see the septum is touching or kissing the posterior wall and leaving the left ventricle empty at the end of systole. And the right ventricle wall is not contracting. And then we have parasternal long axis view with the outflow tract, and they have the Doppler. And with the Doppler, you can calculate the cardiac output. You can realize now the outflow Doppler as VTI is very small. Cardiac output is very minimal in this case. And then look at the duct. You have the duct in this case, that is the ductal view. So you have the pulmonary artery, if you are not familiar with the echo. And you have the left pulmonary branch, right pulmonary branch, and you have the PDA, large PDA, and the color of the PDA flow is blue. Means that the blood flow is moving away from the probe. It is right to left shunt. So entirely 100% right to left shunt of the PDA in this case. So now I have the second question in this case, Dr. Yahya. So you have two options, either start nitric oxide based on the images, or I need to do more assessment, like more calculations, and ask for help, ask for someone else to help. So if you are confident about the results of the echo, start nitric oxide. If you are not really confident, you need to do more calculations, select number 2.
Okay, so you can answer now?
The second question.
Yeah, but
Number
I
2.
think because they are all linked, they need to answer the first and then the second question.
Yeah, no problem, can do that.
Yeah. You don't need to text me, only select on the poll so we can see the percentage.
Yeah.
Yeah, I think we're done. Let's stop.
Okay, that's good enough. Yeah.
Okay, so you have 96% for the third option, none for the first or no, second question. Sorry.
Yeah, that is Second question you have.
Second question you have 69% for the second option and only 31% for the first option.
Yeah. So more than 2/3 selected the second option, which is good job. So you have enough percent to change the constitution. Very good. So let us analyze one by one. Start nitric oxide. Is it a good option or not? It is harmful option in this case. And I will tell you why once we move more to the next analysis. Let us go to the echocardiography. The calculations for the echo. So cardiac output in this case, as I mentioned, was very low. So you have low cardiac output was 65 for the left ventricle, was only 60 for the right ventricle. That's very low cardiac output, even for the first few hours. And you have LV performance in this case was impaired, LV filling was reduced, and RV performance was impaired, and pulmonary artery pressure. Now, like I think that's a new lesson now that probably you need to keep in mind. So in this case, you have right to left shunt through the PDA, but not because of the high pulmonary artery pressure. In this case, was because of the low systemic pressure. So you have very low systemic pressure, very low systemic blood flow, and the PDA is actually helping to compensate for low systemic blood flow. So it is the same like coarctation physiology. When you have very minimal post-ductal flow because of severe hypotension, and the PDA is helping. So in this case, the blood pressure was normal because of the arterial line, which is the ductal, the umbilical arterial line was post-ductal. So detecting the blood pressure post-ductal. So after the effect of the PDA. So if you are able to detect, to measure the blood pressure pre-ductal, you will get very low blood pressure in this case. Now the PDA is helping to compensate for the low systemic blood pressure. So the right to left shunt is not because of the high pulmonary artery pressure, it's not because of pulmonary hypertension. So it is subpulmonic systemic pressure, not suprasystemic pulmonary artery pressure. So it is the opposite in this case. If you have someone from our colleagues evaluating the echo from his office without understanding the blood pressure at the bedside, blindly he will recommend nitric oxide or based on the echocardiography only, and will write in the report there is suprasystemic pulmonary artery pressure. But if we put everything all together, now we'll understand there is compromised systemic circulation and the PDA is life-saving here. So it is contraindicated to give a medication to lower the pulmonary artery pressure. You need to improve the systemic pressure. And once you have the PDA shifted left to right shunt, now you should be very assured about the systemic circulation. In this case, we have right to left shunt, and you have large PDA. And once you select everything, you can calculate systemic vascular resistance, which in this case, I think now we understand more that this infant is behaving like category number 2, because the blood pressure here was normal, the systolic blood pressure was normal, and you have severe high systemic vascular resistance. In category number 2, one of the mechanisms, you have postnatal failure of adaptation after separation of the placental circulation, which is low resistance circulation. Sudden increase in resistance, the heart might not actually compensate for that, and the heart might fail and might actually unable to create enough output or enough stroke volume. So now, after putting everything all together, now we understand the physiology in this case, and we know how like the next intervention makes sense. Should avoid nitric oxide. We should consider to fill the tank because the left ventricle was underfilled, and then we should consider a medication consistent with the high systemic vascular resistance and also inotropic support. So give fluids and give low dose of dobutamine. This infant improved within a couple of hours on just 5 mics of dobutamine and after just 1 bolus of normal saline. So you see, when you consider targeted medication or targeted management, you will get the improvement right away. So in this case, either to consider oxygen, if you have near-field spectroscopy, I'll show you the part of the software. If you have NIRS, you need to enter the hemoglobin, and the hemoglobin in this case, you need to enter as gram per ml to calculate the cardiac output. So you have 120 milligram per deciliter, make it 0.12. And oxygen saturation was 95. And you have the cerebral oxygen extraction in this case was just 50. So borderline low. And when you click calculate, the software will calculate for you the fractional oxygen extraction and give you impression about the level. So it was high because 0.47 is high, more than 0.3 is high. And total oxygen delivery was 10, which is very low. That's just one step prior to lactic acidosis. This lactic acid was 2.7. If you wait just a few hours, you will get the oxygen delivery decreased further, and you will get very low lactic acidosis and very low cardiac output, leading to anaerobic metabolism. So now we understand more this infant compromised, and we understand what level of compensation. Remember the 4 mechanisms. For sure, he's beyond the first mechanism. He's beyond the autoregulation. And now he's at the 3rd mechanism, which is increased oxygen extraction, and just one step before the lactic acidosis, or the 4th mechanism of compensation, which you should avoid. And then if you end the report, did not give you the category because it was based on the blood pressure category. Here in this category, you have category number 2. The software will help you to understand what could be the causes to fit with the clinical context. So for this case was failure of postnatal adaptation, the first and the most common cause of this category. Recommendation, echo is mandatory. Without echo, you will not understand. And it also depends on who's doing the echo. If you have someone did the echo and just looking at the echo from his office without putting everything all together, then he will miss the physiology, and they may consider a medication or intervention which might not be helpful or might be harmful. In this case, we consider fluid because of the low end diastolic volume, and also we consider dobutamine or vasodilator and inotropes. If you end the report, the final report will include everything we entered, including the blood pressure, the cardiac parameters, everything here. And you need just to enter the patient details and print it or have it as PDF. Now I have the 3rd question, last question, Dr. Yahya.
Yeah.
What would be your recommendation? Now I think we answered the question, so it should be very easy. The 3rd question. Fluid with inotropes, fluid with diuretics, or fluids only? And we answered the question, so I'm assuming that we'll get 100% the right answer. Yeah, that's number 3. I cannot see number 3 at the bottom. Yeah.
Yeah, number 3 at the bottom.
Okay. Okay, very good. So I think that's enough.
Okay.
I can see some of you selected fluids. No, I think that's so. Yeah, so the option, as you can see here, not exactly as written. So it should be fluids with inotropes, because he was not edematous.
Oh,
so we should select fluids with inotropes in this case.
Mhm.
So now if we need to understand the physiology behind this case. Sorry, yeah, I think that's mixed between the case number 2 and case number 3.
Yeah.
So anyway, we need to understand the physiology. So now we have a case underfilling, so we have to prime the heart with fluids. It is very dangerous to use inotropes on top of empty heart. So you need to prime the heart with fluids first. And if you are using inotropes like dobutamine without echo, it's better to prime the heart with fluids. Just 10 ml of bolus, normal saline, and then give the start inotropes after that. In this case, dobutamine is a makes sense medication because you have high resistance, high afterload. And also you have poor contractility or poor performance. This case improved after 1 bolus of normal saline and just 5 mics of dobutamine in just 2 hours. So that's the second case. I think that's enough, because I think more than that will be too much.
Yeah, definitely.
Maybe in the future we can discuss like more case scenarios, but I think that's enough for today. And I'm ready to accept more questions. If there's any question, or maybe if you would like to end at this point, it's up to you.
Okay. Any questions? Anybody can ask questions? Questions? Okay. Just people are thanking you. Yeah, you can ask the question.
think probably they are muted or so.
No, they can text me the question. I'm
Okay,
looking.
yeah, sure.
Dr. Ving Ping has a question. Yes, please go ask the question. Okay, they're just thanking you.
Okay, thank you very much. Yeah, I
So
appreciate
Ving
that.
asked you a question is how the in preterm infant. Okay, well, he has many questions. Dr. Sundus is asking you how we can have the blood pressure number or can we have it as a gestational age? That's the question.
Yeah, I did not get the question.
He meant is there a numbers of blood pressure in comparison with the gestational age?
Yeah,
Is
there's
there
centile tables. Like I think you know, Yahya, that we have been relying on centile tables for gestational age, starting from 22 weeks up to 45 weeks, corrected. Yeah, and we can share the tables.
Yeah, I mean, I think she meant, Dr. Yasser, that people using like gestational age plus 10, having the diastole, like some calculation depend on gestational age. Which
Yeah,
totally...
fixed calculation, no, that's not really accurate because the numbers are very different from week to week and from term to preterm infant and from postnatal transition to after that. So yeah, they're like considering a calculation for very heterogeneous kind of centile curves for premature infants, the calculations are not very helpful. You may have that for maybe 2 years old infant or so, but not really helpful for neonates because they are very variable and they are different from early postnatal to after post, beyond the postnatal transition, from preterm to term infant, from HIE to non-HIE. So we cannot rely on like a very simple equation. And you know, in POCUS New, I have to mention that in POCUSnew.org, there is actually a calculator available, and it's not the same like the complex calculator I showed you now. It's a simple calculator. You enter the numbers, and it can give you an idea about acceptable, good, or high blood pressure. So if you go to the blood pressure calculator on POCUSnew.org, it is available on the website. The website is under maintenance, so I think it will be the website will be available soon, maybe tomorrow or within 2 days.
Okay. Dr. Ving Peng Dang asking you, how common the PPHN in preterm babies?
Yeah, that's a very good question. So there is two extremes of pulmonary hypertension in infants. The infants with very premature, like less than 26 weeks, from 22 to 26 weeks, especially if they are born as IUGR, intra-atrial growth retardation, they are susceptible to develop pulmonary hypertension and is really resistant to improve after nitric oxide or pulmonary vasodilator. It's really difficult to manage. And the other extreme is term and post-term infant. In between, the curve is less. So you have high curve at very premature infant with, especially with IUGR, and then that curve will drop at around 30 weeks and start to rise again up to term on post-term. So there's two extremes, susceptible for pulmonary hypertension or development of PPHN.
Okay.
There is an article published from Dr. Lakshinawar Seema. It's a very nice article on animal studies based, and we understood these two extremes from the article.
Okay. Dr. Tariq is asking about the first scenario. I don't think this is time. Dr. Sundus telling you, can you provide us this table kindly? I have the table, I can give it to you. I mean, if you mean the normal blood pressure curve, the systolic,
I am sure that you have it, yeah.
The pulse pressure with the gestational age, with the weight.
Yeah, we just refined the table recently. I will send you the updated one to be sure that they have the updated one. We just refined the table recently. I will send it to you again. And we have also the calculator on the website. You can even upload it on your cell phone and you can calculate at any time. Probably I can share it with the group. Once we have the website done with the maintenance, I can maybe share it with the group and the WhatsApp or the Telegram group.
Dr. Ving Ping asking you another questions. it's like a comment, but I think he meant a question, saying that delayed transition and PPHN may coexist. So is the systemic vascular resistance the main parameter to differentiate these two conditions and help us to decide whether to initiate nitric oxide or not?
I did not get the point. So if you,
delay transition and PPHN, they are the same, I think.
yeah.
Delay transition.
Failure of the transition or failure of adaptation, yes, with PPHN, yeah.
So is the systemic vascular resistance is the main parameter? I don't understand the question.
Yes, no, I think I understood it now. So the differentiate between the typical real PPHN and also compromised systemic circulation, and like the shunt is right to left. Is it because of the pulmonary hypertension? True one. So the most important to evaluate in detail the systemic blood flow and the pulmonary blood flow. So you need an echo, and you need the blood pressure parameters in details, and you need to calculate the systemic vascular resistance. So the all of the three of them. So the typical scenario that I should use, not very common scenario, but it happens and very common to be mismanaged. So you need to evaluate the blood pressure. You will have the blood pressure might be normal, but you have at the same time high lactic acid or pulses alternans. So you have a sign of decompensation. You evaluate by echo and you have poor myocardial performance or decreased low cardiac output. So LV dysfunction or LV low output is very important. If you put a normal blood pressure with the low cardiac output, you will get the result is high systemic vascular resistance. So they are related. They are not really separated parameters. So we have infant with and you have at the same time pulmonary hypertension should be symptomatic. So you should have infant requiring high oxygen intake. So FiO2 in this case, probably I forgot to mention, was just 30% FiO2. And PPHN, you have 100% oxygen or more than 70% oxygen requirement. So PPHN should be also symptomatic from the hypoxemia point of view.
Okay.
And low blood flow systemic should be presented as high resistance, high systemic vascular resistance, and low cardiac output from the echo. So typically you need to put everything all together, and everything should make sense when you put the pieces of the puzzle all together.
Okay. Are you tired or you want to take more questions?
No, that's okay. I can accept more questions.
Okay. So Dr. Ahmed Abul Fath Salim asking you, can I accept low blood pressure in the first few days if other parameters are normal, like CRP, not CRT, I don't think you meant CRT, urine output, lactate, and accepted echo, especially if the baby is sedated, like in case of HIE?
Yeah, that's very smart and very good question. So thank you very much. I have to stress on the trend of the blood pressure. So if you have the blood pressure, even low blood pressure, again, remember that in HIE, if they have the infant on cooling, we are accepting actually lower than acceptable for term infant blood pressure, because the aim of cooling to maintain a low level of metabolism and avoid hyperperfusion injury. So we are accepting lower cardiac output, we are accepting lower blood pressure as far as other parameters are normal. So normal lactic or the trend of lactic acid, because could be high at the beginning, is going down, and urine output is acceptable, like around 1 ml for HIE should be enough. And the most important parameter is the trend. So you have normal trend of the blood pressure, not going down trend, not decreasing trend. So you have plateau trend of the blood pressure. And normal other parameters, you don't have to do anything. Again, in HIE, we are accepting lower blood pressure. So to make it simple, for term infant at birth, for postnatal transition, there is lower acceptable blood pressure. We'll consider this limit, which is postnatal transition, for the entire period of cooling for HIE. And then we'll consider the entire period of cooling as postnatal transition to avoid unnecessary intervention, which is very common, because if you use a medication to improve the blood pressure as a number unnecessarily, you will overcome or contradict the benefit from cooling by reperfusing the brain with sudden increase in the blood pressure.
Dr. Dua Ismail is asking you, can we give dobutamine just after the first bolus, or we need to do an assessment after the bolus and then start the dobutamine?
Yeah, that's a very good question. So if you are available at the bedside and you give a bolus, and if you're able to do an echo, like right after the bolus, it is for sure it's better, which is, I think it's technically difficult. The limitation of that, don't expect that the bolus will improve the blood pressure and filling forever. It's just for a period of time until you start the true medication. So you have to start both at the same time. So start the bolus, and you have about 15 minutes. Once you start the vitamin, will not start right away. You have half-life about 15 minutes, 10 to 15 minutes. And remember, you may start as low infusion rate. So to reach the blood, to reach the infant from the syringe to the body, you may need some time. So you need to start both at the same time. And yeah, you don't have typically to do, if you're able to do frequent echoes, that would be the best, because you may need to give more boluses, more than one bolus. Again, try to avoid to give unnecessary extra boluses, because that might contribute to IVH if you give more boluses during postnatal transition.
Okay, Dr. Mona Salah, she is one of our best fellows. She's asking you, in the previous case of post-operative baby with hypoalbuminemia, do we give fluid as bolus or by increasing the maintenance fluid?
Yeah, that's very good question. So the fluid intravascular volume should not be as a maintenance. Maintenance will be just a maintenance, because the maintenance will be with low osmotic pressure, will not really increase intravascular volume significantly. So you should consider to optimize the maintenance, but the intravascular depletion should be treated with giving boluses. So in this case, we consider to give boluses every 4 to 6 hours, about 20 cc per kg, with frequent assessment of echo, like at least twice daily, until we get the intravascular volume improved. And the clinical pulse pressure started to widen. Widening of the pulse pressure with the improvement of filling by echo, it was a sign that the intravascular volume now restored, and you can start after that Lasix or giving albumin with Lasix. But typically the intravascular depletion should be treated with boluses. The maintenance, increasing maintenance, will take very long time to restore the intravascular volume.
Okay, so asking you also how we can achieve this software. I think Dr. Yasser talked about, you have to go and register in the website.
Yeah, but on the website, we have only the blood pressure calculator, the simple one. The blood pressure, the complex software will be available after we announce for the premium membership, will be another level of membership, and after we conduct a workshop. It is not really safe to offer a complex software without offering a proper training, how to use it. Otherwise, it might be harmful to use it without understanding the physiology. So it will be offered after like a workshop to teach how to use it. So it will be multiple levels. So hopefully that will be soon. We'll announce about that. So follow focusnew.org website, and you will get like the update about that on the website.
I will share the website, the link in our Telegram group and in our Facebook group.
Okay, so it is under maintenance probably until tomorrow or after tomorrow. Yeah.
Great. So Dr. Tariq, are you tired, or you can answer more questions?
Yeah, we can have one more question. No problem.
Dr. Tariq is asking you, in the first question, this is a very cooking question for him. In the first case, is if there is an edema, and the filling of the heart is okay, and cardiac function is okay, can we consider the Lasix and the albumin, or Lasix without albumin?
Yeah, that's a very good question. Okay, so we consider to give the Lasix after we restored the volume. So if you have normal volume, intravascular volume, and normal heart performance, you can for sure give Lasix. And you detected that once you start the Lasix, the kidneys should be very sensitive. If the kidney is depleted as a volume, the kidney will not respond to the Lasix. If you have normal intravascular volume and the infant is oliguric, and the kidney is functioning well, the infant should respond to Lasix. You may consider albumin if you have very low albumin level. Albumin half-life is long time, so you can give it, but just you need to avoid albumin in one condition. If you have acute capillary leak syndrome with high inflammatory process, like post-operative for 2 or 3 days after OR, or someone with infection with capillary leak syndrome because of the significant inflammation on the high CRP, probably when you give the albumin will be lost in the third space and will drag the water, and you will have more aggravated intravascular volume depletion. So give it only if you are sure that there is no significant inflammatory process going on.
Okay. I think we're done. I think you're tired now. And if you guys have more questions, you can post it on Telegram and I can forward it to Dr. Yasser and he can answer it when he has
For
it.
sure, with pleasure. Yeah.
Okay.
Yeah, for sure.
So
Yeah, thank you very much.
Was amazing. Was really a pleasure and an honor to listen to you. I congratulate you on all the work that you're doing. You're always surprising us. Everything and always new. And I don't know what to say to thank you enough.
No, thank you very much. Actually, it's my honor and my pleasure to share my humble knowledge with you and your colleagues, your group, and everyone joined us today. Yeah, thank you very much.
Thank you
Dr.
very much.
Yasser, Dr. Yasser, I should appreciate the presentation and the scene behind you. Very beautiful scene.
Next
Yeah,
session, what time?
Yeah, it is actually the Golden Bridge, I think, in San Francisco, but it is not actually, I am not there. So just it's a virtual background.
It's a fake virtual background.
Yeah.
Very nice.
Yeah, thank you very much.
Next session, Dr. Yasser. What time?
Like we probably will announce in the future about the next session. We don't have that, inshallah.
Inshallah.
On the group, yeah, just if you are following our groups.
On July 14, I'm doing a webinar about use of NIRS, 3 sessions, and we'll have like 15 case discussion, and we'll have a lot of questions. And we'll use also smart, what I call it, smart use or smart monitoring of NIRS. We will talk about histogram, about linogram, about tachogram, and about point care. And if you want to join, it will be a little bit of addition to what Yasser said, because he didn't
it will
talk.
be like very great addition, I'm sure.
Yeah. So if you want to join, the link is there and you're most welcome. And I will make sure that, I don't know why people have some difficulty to join today, but I will make sure that lots of people can join.
Yeah, very good. Yeah,
thank you
very much, everyone.
In our time is a good night, but I know in your time is good afternoon.
Yeah, thank you very much. Yeah, thank you.
Thank you very much.
الله يعطيكم العافية. الله يجزيكم خير. جزاكم الله خير.